Diffuse large B-cell lymphoma, which is one of the most common hematologic malignancies, is a disease which currently our primary therapy is successful in about 2/3 of patients. Unfortunately, this very successful frontline therapy has resulted in a decreased ability to have satisfactory second-line therapy that can achieve durable remissions. The CAR T-cell technology has filled this space now and can offer those patients who either don't respond to frontline immunochemotherapy or who have an early relapse within the first year, or those that have gone on and had stem cell transplants and relapse, a form of therapy which can lead to a durable remission. The way I think about it is, if I had 100 patients theoretically with relapsed or primarily refractory diffuse large B-cell lymphoma, only about half of them are going to be eligible for a stem cell transplant. The other half won't be because of comorbidities, age, et cetera. Of those 50 patients who are eligible, only half are going to go into remission with second-line chemotherapy and be transplant eligible. So now you got another 25 of that 100 patients, or 75, that are not going to be transplant eligible. And of the 25 that are in remission and go to transplant, about 10 of them will be long-term remitters, and 15 will move over into the space of recurrence after transplant. And so you can see the majority of patients that either that fail to respond or relapse early after primary immunochemotherapy are candidates for CAR T-cell therapy. Nowadays, patients who fail primary immunochemotherapy for large B-cell lymphoma will be, in most cases, candidates for CAR T-cell chemotherapy. I say that because the standard therapy for these patients is a stem cell transplant, but the majority will either not be candidates for that procedure, that is, they fail salvage chemotherapy and don't make it to transplant, or they're not eligible because of age or comorbidities. So these are all patients that will potentially be candidates for CAR T-cell therapy. So I think it'll be much more broadly applicable to people that fail frontline therapy than stem cell transplant, which is our current approach. That being said, the label for the two approved products, Yescarta and Kymriah, require a failure of 2 prior chemotherapy regimens. So, but I think that really doesn't change the number of patients ultimately that will be candidates for this form of therapy.